Hi, everyone. I'm Alex Koster, the Director of Analytics and Technology for Population Health within the Nemours Value-Based Services Organization. And I'm here today to talk to you a little bit about our Data Access for Student Health, or DASH program. So, goals for today. Very quickly, we're going to go over Nemours and talk a little bit about our Value-Based Services Organization and how we're structured. We're going to give an outline of the DASH project, talk about operational and technical challenges and considerations for this type of program, present a few different models that we are exploring for interventions and how to set up actually acting upon the data, and outline our next steps for the program. So here's our kind of standard about Nemours slide. We are a large pediatric multi-state health system with hospitals in Wilmington, Delaware, and Orlando, Florida. I also included a picture of one of my favorite buildings, which is our clinic in downtown Jacksonville over the St. Johns River. We have both hospitals and over 80 standalone primary and specialty care locations in 5 states. We collaborate with several dozen hospitals and are an academic center with 2 major academic partners. About 500,000 unique patients a year and close to 2 million encounters and close to 1,000 employed physicians. In 2017, Nemours started its value-based care journey, taking on risk and exploring alternative payment models. And one of the first steps was the formation of the Nemours Value-Based Services Organization, which is where I work. This is a distinct division of the organization that really focuses on everything to do with population health and value. It was assembled out of different departments that had previously existed, plus some new areas, including my own, which is a dedicated technology and analytics function to support population health, value-based care, and alternative payment models. Our VBSO also includes our Delaware and Pennsylvania primary care operation, which include 20 primary care sites and around 120,000 patients. By integrating these teams together, we've created a unified structure to address the operation of the medical home, care coordination under our medical management umbrella, as well as care management, hospital-based case management, community health work, and complex patient navigation. Our data and analytics shop includes our Epic analysts for our Healthy Planet population health platform, as well as data analysts with expertise in geoanalytics, statistics, and other models. We have a data integration engineer who kind of is our connection to our interfaces and the movement of any information between us and payers and other groups. We also have within the data analytics team our contract support experts who work on our pay for performance tracking and working with the payers on different reporting and data movement. We have our population health management team that supports practice transformation and projects such as the rollout of our social determinants of health, our medical legal partnership, quality improvement efforts such as reducing disparities for flu vaccines, and projects like that. And again, our primary care administration. So as we embarked as a value-based services organization down the journey of really transforming healthcare and kind of living our new tagline, which is well beyond medicine, which I love, we really wanted to focus on different areas that were kind of non-traditional settings where we could make the greatest impact as a health system. And one of the areas that came up a lot was our partnership with educational organizations, in part because we had a lot of history working with schools on different projects over the years, whether it was exercise, nutrition, setting up early school-based health centers with other partners in the community, and more. We really knew there was a lot that a kind of wellness and prevention focused health system could do in partnership with schools. And we knew that education was an area, and educational attainment, where we could really help transform the lives of children. There are many, many studies on the relationship between education, educational outcomes, and lifelong health. And I encourage you, just Google it, you'll find just amazing material, amazing data. But this one really summarized it. in a great succinct manner. And the link below actually takes you to a lot more in-depth material on each of these bullets. But really, in the United States, education and health are connected, and education and kind of leading the best life are connected much more than many people realize. So during the era of COVID, we've actually seen so much disruption to the schooling of children. We're actually living kind of the early consequence of what happens when children are kind of moved beyond their traditional stability or stable interaction with schools. We're seeing the results of interruption of learning habits, people getting used to using new technology, trying to understand how to manage learning virtually when you don't have that kind of dialogue and interaction in the same way you might have in the classroom. You're seeing problems with technology, particularly impacting lower income households that don't have access necessarily to the same level of technical hardware or technical expertise. You're seeing pressure on family units to suddenly have to manage this whole new way of learning for their kids, including not only addressing like how to connect and make sure that the cameras and screen sharing is working, but also being at home at times, particularly early on in the pandemic. On the other end, you had teachers learning how to actually teach through these new modalities. You had increases in stress and mental health coming from the disruption in schedule, from the lack of social interaction, from just stress because everybody's perceiving stress from the environment, whether it's from the news or the pandemic or just changes in routine. You had employed parents having to leave work to become full-time caregivers and things like that. And you had the impact of the pandemic directly itself with illness. There's amazing statistics as to the impact to children who were not as heavily affected by COVID, but what happened when their caregivers would get sick? What if they were actually cared for by a grandparent? Or what happens when mom or dad is suddenly ill and needs to really get the focus of care at home, or there's added stress because that caregiver is ill, even if the illness isn't quite severe, it's really adding to that mental burden on children. So all of these things have really created this kind of perfect storm of need to really focus on what's happening to the educational achievement of children during this tumultuous time. So even though we were going through a period of a lot of transformation internally and a lot of disruption internally as a health system, we decided it was actually the correct time to launch our initiative to help school districts monitor absenteeism and see what support we could provide in that space to children in our communities. So we launched our DASH program. It's basically modeled after the District of Columbia's chronic absenteeism reduction effort or care pilot program. And they've been wonderful in helping us and sharing ideas and brainstorming. The idea is we would start with a single school district, test out a model, and then if possible, expand to other districts in the state. The project would start with obtaining parental consent for the school district to share absenteeism alerts with their pediatrician. So essentially, when a child hits a threshold of a certain number of days missed, whether it's excused or unexcused, we would receive an alert that would let us know that a child might have a health condition that's impacting their ability to attend school. We would also take advantage of the data exchange to receive other information that might help us deliver better services and support to families, such as whether a child is already on an IEP or 504 plan. Our DASH project kicked off with, basically, I couldn't have asked for a better set of partners. Colonial School District is the district in Delaware that agreed to kind of take this journey with us and to support the implementation of this kind of new model. They work very closely with an organization called the Data Service Center, which brokers and manages the educational data for many of the districts in the state of Delaware, and has a very close relationship with officials in the school district. We also were joined at the table by the Delaware Health Information Network. That is one of the kind of more advanced statewide HIEs in the United States, and has a lot of experience and familiarity with matching, with distributing alerts, with managing panels of patients subscribed to by different primary care practices and more. And then ourselves, we were bringing to the table our expertise with population health, both in terms of kind of academic knowledge or discipline rolling out projects, but also with technical infrastructure for pop health, including analytics and the way to present data for clinical intervention. So each of our stakeholders really brought to the table a different type of expertise that led us to be able to quickly talk about the design of a model that would allow this movement of data to take place and really address or come up with ways to think through how to manage responding to absenteeism or responding to alerts or sharing information back with the respective stakeholders about the problems that we're identifying for our children. So this is a basic diagram of the data flow. And if anybody wants to reach out at the end of the presentation with the contact information I provided, I'm more than happy to dive more in depth about the technical architecture. But basically, the school district has kind of a daily management system called eSchool Plus that they use for day-to-day tracking grades and absenteeism and absences and tardiness and all of that. The data service center can process that information and normalize it and really create really customized data extracts from the educational data, which are then sent via SFTP to the Health Information Network. The Health Information Network has a model for encounter notifications. We call it ENS, that essentially allows, in its current form, primary care practices across the state to subscribe for a patient panel. So they provide a list of patients to the HIE, and in return receive alerts when any of those patients end up in an emergency department or discharged from a hospital, or if they have an outpatient urgent care visit, for example. So that ENS architecture provides a model where a primary care practice can, with a subscription of a patient panel, can receive a series of alerts for patients that they have some clinical relationship with. And the DIN has very clear rules about what that clinical relationship looks like. You have to have seen the patient in the last 18 months. For example, you have to consider them an active care relationship. And so the DIN is actually going to use that structure to distribute alerts about absenteeism to pediatricians. And because it's an existing structure, it's really allowing us to not innovate at every level of the project. It's something that we can really just kind of rinse and repeat for a new purpose. That data, using the NS functionality, gets distributed to pediatrician offices as a simple CSV or Excel file, or in the future, something more sophisticated, like a file that can be consumed directly by an EHR. Other key aspect of this is the Delaware Health Information Network has the experience with patient matching. And in this case, it's actually patient to student matching that's critical in order to make sure that we're able to connect the demographic records that come out of the data service center with patient records for DIN subscribers. And so they were the perfect partner in that case, because it's really going to allow us to leverage that matching capability. So once the data actually goes to the DIN and is transmitted to the pediatric practices, it takes the form of a kind of a daily alert. And that alert, again, could come as a secure email, or in the future as HL7 or a CCD, depending on the model we end up pursuing. They get distributed, in the case of Nemours, to our care coordination team. So care coordinators would receive alerts specific to their clinic. So our care coordinator, Jessup Street practice, would receive alerts for patients that had signed on to the data share through the school that also have a PCP at Jessup Street. With that alert, the care coordinator would be able to look at the medical record for that child and determine if they were already concerned or at risk. For example, if they have chronic conditions, if they have, or kind of a label or a grouping of clinical complexity. That's something we're already tracking as a concern area. If they have a history, for example, of unmanaged diabetes or anything like that, and can reach out to the family that had the absence and inquire as to whether that consecutive absence period was caused or related to a health condition. So the script might be like, hello, I'm calling on behalf of Nemours. We noticed Johnny missed 3 consecutive days of school. Is there a health concern that we can help you with? Or do you need a referral, for example, to another specialist or an appointment with a pediatrician? Once that action has happened, we can help the patient with any follow-up care that is needed, for example, with a pediatrician, follow-up with a school nurse, with a referral for behavioral health, or potentially with a coordination for support with social determinants needs. So as part of this cycle, we can also see if the obstacle that is impeding the child from joining school might be related, for example, to access to internet, if it's a remote, or access to transportation to get directly to school, or if some other disruption, for example, a loss of housing or employment, is actually contributing to the child missing school. So all of this can come through kind of the series of questions the care coordinator asks the family when they reach out about each absence. If it turns out it's not related, and it turns out the child just missed school because the family took a trip, for example, and decided to take the child out for a few days to go to Disney World or something like that, then the care coordinator can log that encounter and no further action is needed. The key is that at each step in this process, data is fed into our data warehouse so that we're able to measure how often we find that the absenteeism was related to a health condition, how often we find that a referral was needed, what types of connections were made, how often we find that there's a social determinant need that was identified and what intervention was provided, or any other type of care. And that will allow us to deliver data back to the school district where we can examine or share any patterns or trends that have emerged, or determine if the project is really identifying healthcare needs for the patient population as we expect. And ultimately, the goal is, one, to understand the patterns and trends better, but more importantly, to support children so that they don't continue to have these periods of extended absence that impact their educational outcomes. So when we designed this model originally and approached Colonial and the Delaware Health Information Network, we knew that we wanted it to go beyond Nemours. This really was not about setting up a model between the school district only for our pediatric patients and only sending alerts to our clinics. So part of that required thinking through what might be different if you were a community practice, for example, that didn't have the same technical infrastructure we did. How would that model work if you were an independent pediatrician or family practice provider, versus how might that model work for us, versus what might we do in the future when we really want to study trends statewide, or at least starting district-wide. So within the first model, we thought about what would just reacting be like? What would simply a case of a clinic receiving alerts and acting on them in the same way they receive emergency department visit information? What would that look like for a practice, and how might a practice with kind of minimal resources, where there's a nurse that does 90 different things and wears 90 different hats, how might he or she react to receiving this information? Then we thought about how might we leverage our population health tools, which allow a little bit more tracking and exception reporting and monitoring, how might we leverage those and then existing infrastructure to really kind of stretch its capabilities to monitoring the students that are part of this program that fall under our medical home. And in this case, we thought not so much about reacting to individual alerts as they come in, but also looking at measures where we could say, well, what % of children in our panel are showing extended absences? And could we do some basic analysis within our EMR to see what %, for example, have patterns of need for asthma, or what % of the time are we actually calling and being told that health is not the reason, or social determinant needs are not the reason behind the absence. So those are things we would incorporate into, again, our Healthy Planet measures. Finally, we thought about what might it look like to really think in terms of kind of true, more public health or true full population analysis, where we would want to provide analytics maybe to the state Department of Education or to the school districts at the district level to really focus on these are the patterns, this is what we're finding. How can we now make investments in communities, or work with transportation providers, or work with other community mental health providers, or other community organizations that support social needs, to really address kind of system-wide barriers we encounter. And so Model 3 is really where we want to get to once we have enough action and activity to build a true data story about the needs of the children that we're serving. The final piece is really that other component that I mentioned as to whether a child is already on an individual education plan or a 504 plan. The idea there was the pediatrician, for example, if a child is missing school because of a chronic condition, the pediatrician would be able to determine if they've already had a school-based plan, educational plan put in place that might support the child who has slightly greater needs for schooling. So if the child, for example, needs extended time because of a condition, or needs support from an additional school resource, and the doctor sees that there is no plan in place, then the doctor could maybe suggest that the parent go to the school and request a plan. This is not really to have the pediatrician author a plan or make recommendations, but rather simply to be an advisor, because they are trusted by the families as to options the parents might have to support their kids' educational success. So here's some of the barriers we faced throughout this project. As many of you know, schools are governed under a different set of laws than health systems. We talk about FERPA versus HIPAA, and making sure that we're meeting the requirements of FERPA to share data between the schools and the healthcare organizations. And we're handling that largely through an opt-in model. So we will only receive data for parents that have opted in. We want to understand better, or need to understand better, what we can share back with school nurses. Once again, going back to HIPAA requirements, but also this understanding of the school nurse as part of the care team, and this understanding of any of these related healthcare conditions being tied to the child's educational success. And that model really is what allows us to think about this partnership and to think about how we can connect back with the school nurses and administration to support the child once they leave our care and they're back in schools and needing support to stay there before they have other periods of extended absence. We talked a lot about what we need in a demographic file to do successful matching with the patient panels that the Health Information Exchange already had. And we focused a lot on the structure of the alert file to make sure that it was straightforward enough to provide the necessary information for a care team to do the right outreach, but that it was not duplicative of the demographic content, because we didn't want to have to reload a full set of demographics every time we had an alert. So we needed enough for matching, but not everything restated every time. Obviously, data movement is huge. And finally, how we might consume the data at the end, which is, in our case, it's how we might ingest first into our data warehouse, but then ultimately directly into our population health platform. So where do we want to go with this? If this works and this project is successful, in the next few months, I will be able to open one of my Healthy Planet dashboards for quality measures or utilization measures, and I'll see a measure that says, well, what % of this panel has high absenteeism? And whether we define high absenteeism as one period of 3 or more absences, or we have one measure for 3 consecutive days versus one for 10 or more days in the year, we'll work through that. I'm not concerned about getting to the perfect measure yet, but rather the idea that we would treat this absenteeism with the same weight we treat somebody who's a high ER utilizer, or someone who has not completed well visits or maintained their immunization schedule. Thereby really integrating this key indicator of educational stability in our population health management tool. This will also allow us to do drill down so we can see what's the impact of being on our asthma registry or being a child with medical complexity, et cetera, on the rates that we see for this absenteeism, to see is that really an asthma problem, or is it so clinically heterogeneous that we don't really see a clinical pattern to the missed school. So you'll see the odd tagline here, empowerment through ambiguity. And where this is coming from is really how wonderful a moment it was when our project team got together and decided that we didn't know what this was going to turn into. We didn't know if it was going to end up primarily being about providing social support to children and families, where the barriers to getting to school were really things that we would manage through our SDOH process. We don't know if we're going to find clinical patterns. We don't know if we're going to find that there really is that reception, or that most of the cases we reach out to actually have a medical component to them. We simply don't know yet. And yet we know that the lesson, what we learn throughout the process alone, is worth the journey, because it's going to teach all of us much more about how we can support children and families in the community. So even if it turns out that the final model looks nothing like what we planned today, we will have gotten enough valuable information out of the process to make it worthwhile. So where are we today? I'm queuing up the sequel. We have already sent out the packets for families to sign up through the school district. Over 1,300 children are currently signed up, and we anticipate starting to receive data. Now that's 1,300 for a district that has, I believe, under 10,000 children in it. And we know that we have not received all the forms yet. So we know the uptake was very high, which was encouraging, because we were concerned we would throw this party, no one would show up. What would happen if we got 20 families to sign up for the share instead of thousands of them? So that part is encouraging. We are testing the sequence of data movement between the data center and the DIN. And on our end of the Nemours side, we have been testing the ingestion model and setting up our data structure, so that early on, before we're going through our pop health platform, when we're just kind of consuming the alerts, routing them to our care coordinators and recording them in our data warehouse, we're ready to go. And we have another major health system in the state ready to follow suit and join in this tracking, which was one of the big wins. Our goal was to design a model that really could scale beyond just one district and beyond just one health system, and knowing that others are ready to follow suit really kind of helps build on the promise that we're going to help all of the children in the state, which is our ultimate goal. So I hope this has been a good overview for everyone. Here's my contact information if you want to reach out with questions, comments, critique, feedback. Have you considered? We welcome all of your communications. Feel free to drop me a line. And thank you for attending today. Everyone have a great afternoon.